It's about 8:45 in the morning, and I am in the suburbs of Nijmegen. It's a gray December day here in the Netherlands. It's thankfully not raining, although it always seems like it could rain at any moment. I'm walking on the sidewalk, which is, of course, next to the bike path, which is next.
Okay, so this is some tape I recorded while standing on the street in Nijmegen in the Netherlands. Now, Nijmegen is a community about the same population as Sudbury, Ontario, or Cherbourg, Quebec, and it's about an hour and a half from Amsterdam, right on the border to Germany. Right now, I'm on the outskirts of Nijmegen, and there's lots of wide, open, green space and brick homes with neat hedges. I came to the Netherlands to tour different primary care clinics and see how their primary care system compares to the one we have here in Canada. As you know, I do lots of research, and I'm always trying to compare how Canada is doing with other countries. One source of data I look at a lot is the Commonwealth Fund survey. It compares primary care in 10 different countries. And in this last round, it put the Netherlands right at the top when it came to access to primary care. That's because 99% of people in the Netherlands report they have a family doctor or place where they can get primary care.
I understand that the average list size for a house doctor here in the Netherlands is around 2,300, which is a lot higher than we have in Canada. At the same time, they seem to be able to provide timely access to their patients. It seems to be a really important contractual obligation with the insurance companies that pay the GP owners.
So you heard me here refer to GPs. In Canada, though, we use the term family doctor, but in the Netherlands, they often refer to their family doctors as general practitioners or GPs. Actually, in Dutch, it's huisarts, which literally translates to house doctor. More on that later. Now, my host in Nijmegen is Dr. Tim Olde Hartmen. Tim is a GP and a researcher, and he's actually also the current president of the North American Primary Care Research Group. When I told him about my interest in learning about other health systems, Tim welcomed me to see his clinic for myself.
I was lucky to meet Tim at a meeting in Washington over the summer, and he was really kind to invite me over to the Netherlands to do a deeper dive into the healthcare system here.
I'm Dr. Tara Kiran, and this is Primary Focus. We're here to reimagine a healthcare system in Canada that works for everyone. And sometimes that means traveling across the globe to investigate what's working and what's not in primary care in other countries. When it comes to how we can do better in primary care, I do think there is a lot we can learn from other countries. There are so many countries around the world where almost everyone has access to primary care, a stark contrast to our situation here in Canada. And for the next few episodes, we're going to be talking about the Netherlands. We'll talk about what makes their primary care system work and reflect together on key takeaways for Canada. Dr. Tara Kiran, I'm here to see Tim. Hi, I'm Dr. Tara Kiran. I'm here to see Tim.
Dr. Olde Hartmen is now at a meeting, but yes. I think he's coming soon. I'm sorry, my English is not so good.
It's okay. It's better than my Dutch. I visited the clinic on a Monday morning, which, coming from Canada, you could assume would mean it's packed with patients who couldn't see their doctor over the weekend. But actually, it's pretty common here today. Patients who visit this clinic live close by. That's because patients in the Netherlands are supposed to choose a GP that's within a 15-minute drive from their home.
I will be with Suzanne, right?
Yes, I will.
So when I arrive at the clinic, Tim's in a meeting. So his colleague, Dr. Suzanne Ligthart, offers to give me a tour while I wait. Tim and Suzanne work here with 6 other GPs who co-own and manage the practice. Together, the 8 GPs share 4 full-time practices and serve over 9,000 patients.
Let me get you. I will install you in his office. Okay.
Suzanne is warm and friendly, and she genuinely seems happy to have me here. In true Dutch fashion, she's dressed casually, but stylishly, in heeled boots, jeans, a colorful wool sweater, and her hair is pulled back into a ponytail. Here's Suzanne.
So, and it's really beautiful.
Yeah, it is. So I can give you a quick tour.
Okay, sounds great.
We know that in Canada, more than 1 in 5 people don't have access to primary care. There are many other countries around the world who figured things out, and I've been on a mission to learn from peer countries where more than 95% of people have access to primary care. The Netherlands is one of those countries. 99% of people have access to a GP who works with a few other health professionals, and they get both timely and ongoing care. I'm hoping that visiting the Netherlands can give me some insight into how Canada can create a better delivery system to help solve the primary care crisis and meet the 6 standards we set out in our Care research project.
Ophthalmology. So they're here.
Like they're GP, like house doctors who have this extra training and ophthalmology.
So how does Canada compare? Let's set some context. There are more doctors here in the Netherlands per capita, about 1.6 times the number of doctors we have in Canada. Total health spending is only slightly higher than in Canada, but a greater portion of the health spending is from public versus private funding. Not surprisingly, they also have higher taxes as a percent of GDP, and there's less income inequality here. And I got the sense that people generally seek care less than they do in Canada. The Dutch, they're a pretty straightforward, stoic bunch of people, and they're pretty direct in their encounters.
We have here one of the rooms for the GP in training. This is the GP trainee. A little bit smaller room, but a nice view.
I will say this is a lot bigger than my own office in Toronto, even though it's smaller. Yeah.
We have an eye room for eye.
In this clinic, they work in dyads. Each dyad cares for about 2,200 people. Each partner works about 2.5 days a week in the clinic so that all days are covered. They're an academic practice, and so the time they're not here, they're involved in teaching and research. Typically, they may see about 18 to 25 people in person, 10 to 15 virtually, and maybe also do about 10 to 15 e-consults. The latter come through an app that allows the doctor and patient to message securely. Patients can actually also use the app to book appointments and see their own records.
Yeah, and here we have another room for like meetings or something like this. So it's
So is it just you and Tim who are the main?
No, we are with 8.
Okay.
We are with 8 here, but we are 4 practices. So Tim has this practice together with Annemarie.
Yeah.
I have a practice together with you. We have all male-female couples.
Oh wow!
So 4 male-female couples, and we all have.
The clinic is open from 8 a.m. to 5 p.m., with the first appointment usually at 8:15 and the last at 4:15. They start their morning with a team huddle, have coffee with the team from about 10:30 to 11, and lunch from about 12:30 to 1. There's a lot that's different, but there are also parts of being in clinic that are just the same as it is in Canada, like doctors and coffee.
This is our coffee space. Here we drink coffee.
Oh, wonderful! And you got a team room.
Yeah. Also for the noise, we have those big things too.
The clinic's located in a lovely renovated barn with lots of windows and large art murals that absorb the sound from the high ceilings. The murals are all photographs of the surrounding nature. Truth be told, it's one of the most beautiful practices I've ever visited. But I'm also told it's actually one of the most beautiful practices in the Netherlands.
Oh, this is, you guys have a nice place up here.
Yeah, very nice.
For, it's beautiful skylights and windows.
In addition to the GPs, the clinic has 4 nurses, 2 for chronic conditions and 2 for mental health. We'll do a deep dive on nurses in just a little bit.
The building next to us.
Oh.
So there's also
the care the health team offers is based on guidelines from the Dutch College of GPs. The college produces guidelines for GPs by GPs on a variety of clinical topics. It also produces tools to support translating the guidelines into practice and educational materials for patients.
On stilts, yeah, they're beautiful.
Yeah, and it's really about connection. That's also nice.
Thank you so much.
I will get you some tea, coffee.
I can get it myself. You go see your patients.
I asked her.
Okay.
I will ask her.
Okay, now Tim is here.
Hi, Tim.
Hi, nice to see you. So good to see you.
Yeah, thanks so much for having me here.
Yeah, how are you?
I'm good.
Did you have a safe trip?
This is Dr. Tim Olde Hartmen. He's full of energy, as you can tell. And in online articles, I've seen Tim referred to as the face of the future of family medicine, or a giant standing on the shoulders of giants. He is very tall. Now he's also the head of research in the Department of Primary Care, and he's one of 8 doctors, including Suzanne, who practice in this clinic.
Yes. I arrived on Thursday and it's been busy. On Thursday we went to an insurance company.
Great.
Yeah, and now I'm here.
Yeah, now you're here.
So yeah, I feel so excited.
Yes.
I've been planning it for a long time.
Yeah, very good. So give me your jacket.
As you know, I'm here to understand how it is that almost everyone in the Netherlands has a family doctor. And a lot of what Tim and I talked about during my visit was just that. How has the system been set up in a way to offer timely, comprehensive care to pretty much everyone? Where Suzanne took me through the clinic, Tim took me through his day.
This is my agenda. Are you taping now?
Yeah, is that okay?
Yeah, that's okay.
That's okay,
Yeah, that's okay. So this is my agenda. So I had a meeting first hour with 2 other practices here in the neighborhood, which we closely collaborate with. My schedule starts at 9:15, but I put a block in it. Kiran is here, so that I have some more space. So this is our agenda, and we work from our agenda.
I learned during my time in Tim's clinic and the other clinic I visited in the Netherlands that much of what GPs do in the clinic is deal with acute problems. The day I was there, for example, Tim squeezed in a child at the end of the day whose parents were worried about a fracture after a fall, and Suzanne, she applied sutures to a toddler who fell and cut their lip. There were patients with belly pain and heavy menstrual bleeding. They also manage patients who have more complex medical conditions or medical conditions that interplay with social challenges. But what don't they do? They don't see well babies. They don't do immunizations, other than maybe a bit of adult flu or pneumonia shots. They don't screen for breast or colorectal cancer. There are actually separate clinics that support well child checks and immunizations and government agencies that organize their cancer screening. They don't do preventive care visits either. They don't think it's a good use of time.
Like that.
I don't do that, but my practice nurse does. So my practice nurse...
We're going to talk about practice nurses more in a little bit because I think this part is really important. And while I'm here to look at the ways clinics in the Netherlands are doing things differently, I'm always struck by how the medicine itself is essentially the same. I mean, we're seeing most of the same chronic conditions, diabetes, hypertension, asthma. The way we monitor and treat these are generally the same. We see people of all ages. Our days are varied with people coming in with different kinds of health concerns. And we take a whole person approach, supporting the person in the context of their values and their circumstances and community. It also seems like we share some of the same types of workforce trends. In Canada, we have a shortage of family doctors with fewer trainees choosing to practice family medicine and family doctors leaving their practice to work in hospitals or in other fields. Tim says that while about 1/3 of medical students in the Netherlands have traditionally gone into primary care, the numbers are changing.
But I just saw the numbers, but also this year we had more residency places than there were candidates.
Okay, that's concerning.
Yeah, but that has also to do with the fact that that they extended the number of GP resident places because they see a shortage of GPs coming, so they have increased the residency places to educate more GPs.
Okay.
So that has also to do with that.
And then the other thing that we heard from the executives at CZ, they said that, and I'd be interested in your thoughts on this, that more GPs nowadays, people who have trained to be a GP or a house doctor, more of them are choosing to be self-employed rather than own a practice. Mm-hmm. And I'd be interested in your thoughts about that. I guess that's the other tension they find, or is that there are enough people trained as house doctors, but more of them want to work part-time.
Yeah.
And more of them don't want to be GP owners.
Yeah.
Is that?
That's the case. That's at the moment. That is the struggle at the moment in the Netherlands. That there are a lot of GPs trained, but that the younger generation is afraid of becoming a practice owner.
Okay.
And I don't understand that because I'm a practice owner. But yeah, I don't understand why people are afraid of that. They are afraid of busy working days and a lot of meetings also in the evenings. And I always tell them, but you are there yourself. So that's something you can decide yourself because you're the practice owner. When you don't want to do that, then you don't do that and you make another planning.
Do you think they don't?
For context, GPs here are small business owners, just like in Canada. GPs can run their own practice, but they can actually also choose to work for another GP who runs a practice. If they choose to work for a GP, they can do so on a regular basis or just ad hoc. But just like in Canada, fewer GPs here want to own their own clinic because of the ongoing responsibility it involves. But Tim and Suzanne, they seem to love the practice they built. GP owners on average, they roster about 2,300 patients, I'm told. It's a big range with, higher roster sizes out in rural areas of Netherlands where I'm told people are even more stoic and don't come in to be seen as much. And smaller practice sizes like in some high needs communities in Amsterdam, like at the clinic I visited there. GPs are paid about 70% by capitation and 30% fee for service. What does that mean? Well, capitation means being paid a set fee per patient, and so GPs are paid more if they roster more patients. Whereas fee for service is essentially being paid per visit. So having 30% of your pay related to the number of visits you have means GPs are still incentivized to see lots of patients. Importantly, the capitation fee is slightly higher if patients live in a neighborhood that is considered more marginalized, as we know that patients who face social challenges can take up more time for a GP. And because they're self-employed, GPs can take vacation when they want. They also can pay into a pension. And while the way GPs operate as small business owners is not dissimilar to how we're set up in Canada, one big difference is that getting timely access to care in the Netherlands is much faster.
We try to see patients within the same week or within 2 weeks. So normally we think that within the same week that's preferable. Okay. But we also have time slots for the same day places for urgency. So urgency can always come.
Yeah.
So
and who monitors that though? Like you guys just feel a level of accountability to your patients that you're going to provide that? Because a lot of patients in Canada, when they have an urgent issue, it's really hard for them to get an appointment with their GP. Like they might be waiting, 2-4 weeks for an appointment, even if it's urgent. And then they go to the emergency department.
Yeah, of course.
But that doesn't happen here, I don't think.
No.
So why not? What do you think is different here?
Because we think when patients have an urgent health problem, you should help them.
Yeah.
As you can hear from Tim's very matter-of-fact response here, providing timely care to patients is just part of the ethos of family medicine in the Netherlands.
So that means that when somebody has pain on the chest, he might have to wait for 4 weeks.
Well, a pain in the chest, I think many patients would probably go to the emergency room anyway. But let's say someone has a very bad back pain and they're not able to do something. I think then they end up maybe going to a walk-in clinic or they end up going to an emergency room because they can't get in to see their family doctor, or even a fever or a sore throat.
This is where Tim seems shocked. The idea of a patient with acute pain waiting 2 to 4 weeks to be seen just doesn't compute for Dutch doctors. And that's because Tim's whole clinic and the clinics of pretty much all GPs in the Netherlands are set up to provide timely care. GPs are truly the first contact for care. You can't go to the emergency department here unless you have a referral from a GP, even in the middle of the night. Now, I know what you're thinking. In the Canadian system, that would just be unfathomable. I mean, how can you require a referral from a family doctor if wait times to see a family doctor are so long, or if you don't even have a family doctor? But that's not how it works here. When you call your doctor's office anytime from 8 a.m. to 5 p.m., or call an after-hours center between 5 p.m. and 8 a.m., your call is answered in a timely way and you reach what they call a practice assistant.
No, there is a triage on the telephone here, and the practice assistant looks how urgent it is. So there are now a couple of calls in my agenda, and the practice assistant asked me, when could you see this patient, because it can't wait till over 2 weeks.
Yeah.
And then I say, put it together.
And everybody feels an
I should mention that the day I shadowed Tim was his first day back in clinic after being away for a week or two. So his wait times for non-urgent appointments were longer than usual. But with the help of his practice assistants, he could still ensure that patients who needed to be seen were squeezed in appropriately. So, if you're a patient in the Netherlands and you call your doctor's office and speak to a practice assistant, there are a few different things that can happen. One, the practice assistant could resolve the issue on the phone independently. I mean, you might have a cold that's been there for a couple of days and they can give you advice on how to manage it. It may be something that's fairly straightforward or administrative, like you calling to change a referral to a different specialist, and they can take care of that. Two, the practice assistant may determine that you need to be seen in person. So they'll decide whether that's best with a GP, a nurse, or themselves, or another practice assistant. They'll determine how long it is that you might need to wait. So, is it appropriate for you to wait a week, or maybe you need to be seen that day? And then they'll also try and figure out, are you able to actually come into clinic to be seen? Or is this a case where the GP needs to do a home visit? We're going to talk more about home visits in our next episode. 3, the practice assistant may think that you need to go straight to the emergency room, in which case the doctor would get involved and ultimately speak to the emergency room physician, explaining the situation. It's worth noting that there is an emergency phone line in the practice that if you call is answered right away. It has a different ring to the others, and patients know to use it wisely. As we'll speak about more, the practice assistants may need to speak to the GP to make some of the decisions about whether, when, and by whom you should be seen. The GPs, they work with them behind the scenes to provide that support, and then the assistants call you back.
Oh, this is a question of a receptor, of medication refill.
While I'm shadowing Tim, he shows me on the computer how he renews a prescription.
This patient also had urine check to start antibiotics, but they didn't.
Now, if Tim was shocked by Canada's lack of timely care for acute problems, I was shocked by how much easier this process is here. Because it's efficient. I mean, he's looking at a patient's file with a request for prescription to treat a urinary tract infection.
So I can just prescribe an antibiotics. And also that is quite, so we have a prescriptor, and that's a kind of IT system, a smart IT system who give me suggestions for what to prescribe.
Oh, wow.
So
does every EMR have that?
Yeah. So I click it and then you can see. So then this is linked with the Dutch GP guidelines. So the system knows it's a man, and it's a man with a urine tract infection, and then he says the first antibiotic you are going to prescribe in man is ciprofloxacin. You also can choose amoxiclavulanzuur augmentin, or you can choose cotrimoxazole. That's what the guideline tells us.
Interesting.
Yeah, and there's also a control in it, because when, for example, this patient have a low renal function, then it also gives a hint, watch out, low renal function, then the first choice will be
wonderful. That's really great. Yeah. Okay, maybe this is not the most riveting part of the tape I collected from my visit to Tim's clinic, but the ease with which he sends this prescription is amazing to me. I mean, in Canada, there are way more steps and way more clicks.
And then it also seemed you didn't have to enter the pharmacy information.
No, because all patients have the same pharmacy here.
Oh.
We have one pharmacy.
Oh, yeah, because it's a smaller place. Yeah.
So
we work with probably 100 pharmacies.
Yeah. So you can put in another pharmacy when you want, but
you didn't need to.
No.
Yeah. Amazing. Okay.
It's just one of a long list of things I noticed GPs in the Netherlands do with much more ease than I'm used to. Faster electronic renewals with integrated decision support, less charting or shorter notes. It's easier to make referrals. And in Tim's practice, they've integrated e-consults seamlessly too.
So do you want to have coffee or tea?
I'll probably have tea. Yeah.
Tea?
Yeah.
I love how in the 2 practices I visited in the Netherlands, the teams take time to have coffee and a snack together mid-morning, and then later on eat lunch together. It's such a wonderful ritual that adds to the camaraderie and joy in practice.
Hi, I'm Tara. And you're from? I'm from Canada, and I'm at
The staff in Tim's practice work hard, but They also seem relaxed and happy, and they have such a nice, easy chemistry with each other.
I speak very well English. No, this is our other practice nurse. This is Diane.
I'm Diane.
Hi, Kiran. I'm Tara.
Coffee and lunchtimes are times to be social. Sometimes they chat about cases, but often they chat about life. And in Dutch fashion, it's an efficient time together. They come, they chat, and then they quickly clean up and get back to work. At the morning coffee, I meet two of the practice nurses and have a chance to shadow them that morning.
Something you should learn.
Well, I want to learn more about what you do as a practice nurse. So actually, I would love to learn more about what you're doing on a day-to-day basis.
I can ask Mariana.
And this is where I meet Mariana.
Maybe some patients speak English.
No, you just do it in Dutch.
Okay.
I do it all in Dutch.
And then I can just ask you a question like what you're doing.
Oh yeah, it's okay.
You can do it in everything in Dutch, but then I just get to see what you're doing.
Yeah, it's okay.
Yeah, because actually I know what a doctor does.
I'm not interested. I'm not interesting anymore.
No, but it was good.
Wait when you taste my salmon lasagna tonight.
I'm told Tim's salmon lasagna is famous the world over. It's what he cooks for all his visiting research colleagues.
You like salmon?
I do.
Okay.
Yeah.
I didn't ask that.
As long as it's not like brain. I'm not into brain.
Brain. No, it's not brain. No.
Now back to Mariana. There are two types of practice nurses in Dutch practices. Nurses who support mental health care and nurses like Mariana who support chronic disease care.
I'm a practitioner.
A practice nurse, right?
Ja.
How do you say it in Dutch?
Praktijkondersteuner, somatiek.
Right, because you deal with somatic complaints.
Yes.
When it comes to chronic diseases, nurses support patients with diabetes, high blood pressure, cardiovascular disease, COPD, asthma, and some also support people who have congestive heart failure and atrial fibrillation.
This is my
This is your office. Wonderful.
office. The practitioner's office is the official is that room. We have a lot of folders, brochures.
Practice nurses hold at least a bachelor's degree in nursing. After they complete their training and gain some experience, they then need to complete a special training program to become a practice nurse in a GP practice. Now, usually the special training involves part-time courses, and it typically lasts 1 to 2 years. Mariana was an ICU nurse for more than 10 years before making the change to general practice, and she needed to do some extra training to make that shift.
10, 15 years.
Oh, wow. And
yeah.
so then you decided to make a change, though, and come to general practice.
Yes.
Yeah. What made you want to come to general practice?
A lot of night shifts.
That's the same in Canada, to be honest. I think there are many nurses who...
Yeah.
Practice nurses help ensure patients with chronic conditions get care they need to prevent complications and ill health. That means regular focused visits to check in with the patient on how things are going, providing education, ordering tests and examining them, and making recommendations about how their condition can be better managed. In Canada, much of this work is done by family doctors. For example, it's typical in Canada for patients with diabetes to have 4 visits a year to monitor their condition. In the Netherlands, it's typical actually for 3 of those visits to be done by a nurse and for the doctor to see the patient just once a year. If a patient's condition is stable and things aren't changing, then they may have even fewer visits overall, and more of them might be done by a practice nurse. Now, the nurse would check the patient's blood pressure, their weight, their feet. They'd order lab tests to check on their blood sugar levels and other things. They can't prescribe medications, but they can make suggestions, and then the doctor kind of just signs off on that. The care they provide is based on guidelines from that Dutch College of GPs that we talked about. And there are actually checklists within the EMR that make it pretty easy for them to remember what are the things that they really need to keep track of when they're seeing people with certain chronic conditions. I also had a chance to visit a different practice, one that was located in Amsterdam, and they operate much the same way as they did here in Nijmegen, even despite a more urban location. The nurses told me they maintain lists of people with chronic conditions and proactively follow up if they are overdue for a checkup. Mariana is one of 2 chronic condition nurses in Tim's practice.
Yes. I assume then if something is wrong, you would consult the doctor.
Yeah.
And then the patient might see the doctor, or you would get advice from the doctor.
Yeah, advice. I had an advice with the doctor, but she has going now to the patient. after the coffee
Yes.
pause, we are going to advise the doctor.
Oh, so you already this morning you had a huddle
Yeah.
and you reviewed some of the patients with the doctor
Yeah.
already that you were going to be seeing.
Yes.
And the doctor gave you the advice that you needed.
Yes.
And then
Beyond that morning huddle, if the nurse needs advice from the doctor about a specific patient, they can book themselves into the doctor's schedule to discuss or send them a message via the electronic medical record system.
so you book at a time within
Yeah.
the doctor's slot
Yeah.
to talk to them?
Yeah.
Right.
We
so
have 10,000 patients.
Yes.
And 8 doctors.
8 doctors, yes.
4 sets.
yes. So you can pick anybody in the set.
Yeah.
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 So you've booked a time with the doctor so that you can consult them. And usually that's like 5 minutes or 15 minutes
50 minutes. And
okay.
Wednesday I have a slot with Suzanne.
about a different patient.
Yeah.
Right.
We
So
have-
From what I've learned about the Dutch system, Mariana's description of her role is not a one-off. The part she plays in the clinic seems pretty standard across the country. Despite the fact that GPs are actually all individual practice owners, there is a consistent way in which they integrate practice nurses. One of my key takeaways: prevention and management of stable chronic conditions takes up a lot of family doctor time in Canada. What could we do if we freed up that time? So let's review. So far, we've toured Tim and Suzanne's clinic. We've met their team, and we started to take a deep dive into how the Dutch primary care system works. We saw how Dutch family doctors organize their practices to take care of a lot of people while still ensuring that everyone has access to timely care, something Canada is still struggling with. And we learned about the important role of practice nurses. But that's just the start. Over the next 2 episodes, we're going to go even deeper. In our next episode, we're going to explore 2 parts of the Dutch primary care delivery system that really stood out to me and that might offer us big lessons for how we can improve primary care back home. Join us next time, and we'll take a closer look at home visits, a Dutch tradition that lives up to the Dutch word for family doctor, huisarts, or house doctor.
wow, you
frozen meat.
really have you had to use those in the people's homes?
Yeah, sometimes. Yeah, especially when
if they're having a
end of
seizure.
life care.
Oh,
Yeah.
And we'll meet the team that I think is the secret engine to helping this system run smoothly.
Hi.
Great job.
Yeah, the practice assistants. Yeah.
Hey, are they nurses? They're not nurses, you said.
No, they are not nurses, but they are almost nurses.
Stay with us. Primary Focus was created by me, Dr. Tara Kiran. Marianne Danash is our research coordinator. Seema Marwaha and Emily Holton are storytelling and media advisors. Our producer is Avery Moore-Kloss. Thank you to Rosemary Hannum for her help on this episode. And a big thank you to Dr. Tim Olde Hartmen and Dr. Suzanne Ligthart and their incredible team for inviting me to their clinic. I can't wait to show you more in our next episode. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on how the Our Care Standard could help us solve the primary care crisis, visit ourcare.ca. Primary Focus is supported by a grant from the St. Michael's Foundation, and I'm supported as the Fidani Chair in Improvement and Innovation at the University of Toronto and as a scientist by the Departments of Family and Community Medicine at St. Michael's Hospital and the University of Toronto. I'm Dr. Tara Kiran. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.